All right, good morning, everybody. Thank you for joining for the second day of Heart Club sessions, our breakfast talks today. We're going to get started off with Michael Danduran. I'm really excited that he was able to come. So Michael is an exercise physiologist, a professor of exercise science at Marquette University, and works with the pediatric cardiology program I was only going to say Milwaukee. That's correct, right?
Children's Wisconsin.
Yes. Okay. And he's going to talk with us today about what it looks like to be thoughtful about how you use resources when we're talking about a resource limited setting where there aren't enough exercise physiologists or exercise cardiologists or physical therapists to go around. So we're really excited to hear from him, and Michael, I'll turn it over to you.
Thank you. So I'm excited to be here. I am going to talk also about kind of like how I became an exercise physiologist in the profession a little bit. And so again, this is Michael's guide to being creative with exercise testing and prescription, and hopefully give you some ideas about finding possibilities both with equipment and people. So with all good books, I guess we need a table of contents, and so I'm going to start with a little bit of that. I'm going to start with chapter 1, which is just going to be a little bit about myself. I'm going to tell you about how a nap can actually change my life. I'm going to give you a little brief history of perception versus reality, and I mean very brief. Now, I'm going to talk about exercise physiology as more than just a cardiopulmonary exercise test, and then helping you find some resources, and then how do we pay that forward and make that worth our time. So a little bit about myself. I met basically the girl of my dreams when I was in high school, and we've been together ever since. We'll be married for 34 years this coming August. I've been to 3 different institutions for my education. Actually got my undergrad at Colorado State. I got my master's degree at Mankato State, which is Minnesota State University, Mankato now. And I am currently just about to finish my PhD at Marquette 25 years after getting my master's degree. So it's been quite a journey, and those different experiences have helped me learn a lot about not only research, but how I want to also share that information. My secondary education over the last 30 years has been at the 2 hospitals that I've worked with. The first one was what was called Children's Memorial Medical Center, which was in Lincoln Park, Illinois, before it became what is now known as Lurie's. I was there from 95 to 2002, and then in 2002, I moved to Children's Wisconsin, and I've been there ever since. I am an avid exerciser. And I think that's important because I think it reminds me that at times I need to not be biased with my own opinions about exercise, and that what I love doesn't necessarily mean that everybody else loves that, or the choices that I make doesn't necessarily mean that those should be the choices that other people make. And then finally, I'm the father of 3 daughters who are now growing into mostly responsible adults. So we're excited about that. So we're getting close. My wife had one rule that is not my favorite rule, and I don't necessarily tell anyone to prescribe by it, but when we had our kids, she said that we were not allowed to travel together until our kids were adult age, because she was so worried that something would happen to us. So my youngest is now almost 18, so I think we can let the travel start. At least together. We travel a lot as a family, which is both fun and stressful. So chapter 2, how a nap can change my life. And I know this sounds really kind of silly to talk about it this way, but when I was at an ACSM conference, which is the American College of Sports Medicine conference in 1995, I saw on a job board, this was before cell phones were prominent, and you wouldn't go up to the job board, and there was a napkin on the job board, and it literally said, Children's Memorial Medical Center looking for exercise person, must like kids. And I didn't take down the information. I stole the napkin, and I called the gentleman on the line and got a hold of him at the hotel that he was at, and he asked if we could meet the next morning. And it was 3 months later, I was moving to Chicago to take that position as an exercise physiologist in what was the cardiopulmonary lab. I had no intention of ever being a clinical exercise physiologist. All of my training up until that point in time was in performance medicine, where I was actually at my time at getting my master's degree, I was working with the Minnesota Vikings, doing a lot of their professional testing and things like that. So I thought, Chicago, what a great opportunity to get me into a town that would allow me to work with a lot of different professional athletes with professional sport teams. So I actually moonlighted with the Blackhawks for a while. I did all their performance testing. I worked with the Chicago Bears for a little bit. But every day I would go to the hospital and I'd meet these incredible kids that I would be spending time with. And I realized that I liked working with them much more than I liked working with the athletes. The athletes were great, but when they did well, that was because they were great. And if they didn't do well, it was because you didn't prepare them well enough. And you would walk into a kid's room and they just light up because they were just so excited that you were going to do something with them that was play. And I immediately learned that play was a word I was going to use pretty much through the rest of my career. So the second time a napkin changed my life is one of the cardiologists I work with then went to Children's Wisconsin, and she went up there. She was avid in their exercise experience, but they didn't really have a fully developed lab, and it was underutilized in some ways. So at that point in time, I got recruited to come up there, and I went in and I was meeting with Stu Berger, who was the division head at the time, and he came in, and he was always a couple minutes late, and he walked in and he had just finished a cath, and so he walks in and there was nothing on the table, and he had a napkin in his pocket from a bagel he had been eating, and he put it across the table and he said, "What can you do for us?" And on a napkin with a pen, I said, I think that based on the number of kids that you have here, and I had done my research up front, I said, if we build a lab and if we buy this equipment, if we do this, I think we could probably doing 500, 600, 700 studies a year, and I think that would pay for itself and do those things. And so that was the second time that napkin changed my life, because never having been in Milwaukee or anywhere near Wisconsin, that led to the next 22 years of my life, which is my current existence right now. So never underestimate the power of a napkin. So with that being said, how did we do once we got to that lab? And so this is where we were at after my 22 years there. We'd gone from a lab that in the late 1900s, or 1900s, late 1990s, I told you I was old. We were doing somewhere around 300 to 400 studies. And when I got there in 2002, we immediately bumped that up. We doubled that number almost. We started doing about 600 studies a year. And we did some really unique things that at the time were thought of as being a little different. But we implemented a program where the physician didn't need to be in the room. So we did all the testing on our own. We had the ability to call in the physician if we thought that it was going to be relatively high risk, if we were worried about that. But otherwise, we vetted all of our studies up front. We looked at all of that, and we decided that we were going to go ahead and do that with physician availability as a physician without a physician in the room. And when we did that, it worked out really well because it allowed for freedom in scheduling, and we didn't have to necessarily wait or time things like that. Our numbers went up. I spoke to every group I could possibly speak to at the hospital. I did what they called tea rounds, and I did house meetings, and I gave a ground lecture on exercise. And over that time, we really increased our referrals, not only from within the heart center, but also across the hospital. We were doing pectus evaluations, we were doing asthmatics, we were doing a lot of different things. So it really created a very cool environment. And then as the lab grew, we became much more just cardiac focused. So this was just an idea of our referral pattern after about 10 to 15 years. And on the top, you can see that we did a lot of others, and those others could be anything from, again, pectus referrals or obesity or any of those interventions. But the majority of what we were doing was congenital heart disease, arrhythmia, palpitations, chest pain was a large percentage of our population. And if you look at our CIHD referrals on the bottom, it kind of gave you an idea that we were doing something that was different. I put this picture up there because one of the things that I really wanted to do was I wanted to demonstrate to the cardiologist that I was working with, first of all, the value of exercise testing, but not only that, but I wanted to throw out the stereotype that there is a certain age or a certain person that should be coming to your exercise lab. And I wanted to say that if you wanted or had an exercise question, we could answer it in some ways within that lab. So this is an example of a 4-year-old with hypoplastic left heart syndrome who was doing full metabolics and everything. And we started doing young patients. Now, it didn't always work that well, right? But we were able to do that. And our cardiologist bought in because what it allowed us to do is start kids early so that when they came for second test or third test or fourth test, they were that much more comfortable with it. And the stress test or the opportunity was less intimidating to them. So just looking at that and thinking about our Fontan population, over the course of our years there, we've done somewhere, this is a 10-year perspective, if you will, but this is 911 cardiopulmonary exercise tests in Fontan patients, but it represents about 436 patients. Some of them have had multiple tests. And so what we did is we just broke down, because it was a common thing where our Fontan kid would come in and they would say, or our patient with Fontan, and our doctors would say, well, how does that compare? And we'd be able to compare them to normals, if you will, which was quite obviously not what we would expect them to be. But we wanted to be able to compare them to other children that had Fontan. So we created some normative data for that we're working to try and finalize and get that published soon. We also did that with the VO2 data as well. And this is from ages all the way from 7 to 20 years of age. And so again, this is 911 patient test in 436 unique individual patients. So when we look at this, we break it down. This is just A is our males and B is our females. And I apologize, this is all pretty fresh data that we've been working with, but I wanted to share it with you. You can see that especially in our females, which is the B graph on the side, there seems to be this magical time where, especially once they hit those pre-adolescent or teen years, and we see this in the males, but just not quite as significantly, there's a pretty significant decline that takes place. Now, whether that's because of social issues where there's less participation in sports, whether it's because of development that takes place at that point in time, whether it's because of a lot of different issues, we targeted this time to think about, should we be intervening in those patients even a little bit earlier than what we might already think possible. So again, with this being said, I think that we need to consider this idea that the perception of what we did was really cool. And when you take the perfect picture and the ball is in the right place, you look pretty cool doing it. But the reality is that most of the time, people don't always know what they're doing, right? We had our outfielder who's got his hat in his head, and clearly this is a much less flattering picture of me playing shortstop than the time before it. And so what I put up there with this is that sometimes I think we create standards for the work that we do, and then we hold ourselves and we limit to those standards at times. And so when we do that, what happens is I think we are less flexible in the way that we do things. So I think we need to continue to be creative while standardizing also what we do. And so there's a lot of limiting factors with our 4-year-old that comes in. Yeah, there's age issues, there's apprehension about procedures, there's lots of issues with size of equipment. It's one of the reasons why we do treadmill at Wisconsin, but a lot of people will do bike. And I don't think that there's a right or a wrong to it. But on a bike, it's a lot harder to get a 4-year-old on a bike just based on size and availability. So short of that, a treadmill is one size fits all. As long as my patient can walk, I can test them on a treadmill. And so we've really used treadmill because of its ability to be used across the age span. But there are some limitations with equipment, and there are some physical limitations, and they're also symptom limited in the sense that, are we getting a true maximum when they're all of a sudden claiming that they need to stop because they're feeling their heart race, which is an incredibly normal sensation for exercise, but they just might not be used to it. So that may made me want to go back, if you will, and think about, I used to work with these high-level athletes. How can we do these things that we potentially did with athletes and carry that over into a clinical setting? So when I remembered that exercise physiology is more than a cardiopulmonary exercise test, and I know that sounds really silly to think that way, but when you do this every day, it becomes a little bit routine and it becomes mundane. You do your process all the time. You forget about all of the other things that you used to do that really brought you to exercise phys and why you loved it. And so over the next few slides, I'm going to try and share that we can translate some of this performance exercise physiology into this congenital heart disease research and some level of practice. And so I broke it down into 5 different categories. I said that we can add measurements or equipment that aren't necessarily typically thought of when we do our testing. We can think about some adjunctive or alternative testing measures. When minimal resources are available to us, what are some testing that we can do? We can borrow some ideas, and we can potentially recognize some barriers that exist that make it tough for some kids to exercise. And so these are things that I came up with just to share with you. So the first one I'm going to talk about is this equipment idea. I give the fellow lectures at Children's Wisconsin and have done so ever since we started our fellowship program. And I think it was 2004. And I was talking to one of our fellows. His name was Rohit Rao. I believe he's down in San Diego now. But we were doing a lot of NIRS work in our surgical suites and in our ICU. And he said, he joked a little bit. He said, you and I, we pray to the same God in the sense that we're using the stress or we're using something to implement a change in homeostasis or failure. How do we potentially look at that as a research option in the exercise lab? So we brought the NIRS monitor down. I did some work, and they used near infrared spectroscopy in elite athletes a long time ago, especially with cyclists and things like that, to look at perfusion deficits and skeletal muscle at the rec fem. And so we took a foresight approach. We put one on the brain, we put one on the kidney, we put one on the shoulder and one on the leg. And we ended up doing maximal exercise testing with near infrared spectroscopy in normal patients just to see what it would look like. We wanted to know that the kidney and the brain were acting differently than the muscle. And so that was the reason why we did two-site muscles, so that we can confirm that they weren't having similar trends. And when we thought about it in our normal patients, we were able to really look at that data, and we determined that anaerobic thresholds can actually be predicted pretty sensitively by brain saturation with exercise. So a lot of us think about what limits our exercise when we're out running. Is it our legs? Is it our heart? Is it our lungs? And it might actually be our brain that's starting to tell us when we reach a point where we're no longer giving the oxygen saturation or the oxygen requirements that we need. It changes CO2 patterns, it does all this other stuff. And that was the thing that we were finding that was correlating really well with this idea of anaerobic threshold. And the other thing that was beautiful about it, it was incredibly non-invasive. It was stickers on the body. And so, of course, we had to bring that into our CHD population. And so this is some of our work from the Fontan group. Now, this is a really, really busy slide, but we did immediately, we looked at 36 different kids with Fontan single ventricle, and we divided them by left and right. We divided by fenestration versus non-fenestrated. We went based on age. And we looked at everything from their renal saturations to their brain saturations to also their muscle saturations, which I'm actually diving through that data now more. But we went through, and this became a really vital source of research for us. We were able to publish almost 6 papers over a 4-year period of time. This guided our tilt table testing, which I'm not recommending at all. But what we did is we started to put a NIRS patch on the brain during tilt table testing, and it was much more sensitive than blood pressure or heart rate changes because we'd see a cerebral drop in saturations. And we could pretty much predict within the next 30 seconds to a minute what was going to happen. And so this became really just great data for us that was non-invasive. It was well tolerated by the kids. So to give you an idea of what this looked like, this is my daughter just being a subject, so I could use the picture, right? But we had, this is obviously a long time ago, but we put 4 different NIRS monitors on. We had one on the quad, we had one on the deltoid, we had one on the kidney, and one on the cerebral saturation. Then we had full ventilation, blood pressure cuff, and then with all this stuff on, we asked them to give us a maximal effort. Now, this is also a busy slide. The solid lines are our normals, and our dotted lines are our Fontan patients. But what I would ask you to recognize more than anything else is the pink solid line that runs a little bit between the 60 and 80, about 70%. That's the brain saturation in normal patients, which you can see remains incredibly stable up until some point in time when anaerobic threshold hits, and then that brain saturation starts to drop. And when that hits to a certain point, we see that there is some level of need to stop. In our Fontans, the brain saturation is the solid kind of purple triangles with the dashed line, much lower brain saturation to begin with, and almost a precipitous drop that continues throughout. And so we noticed that right away, there was different patterns in the blood circulating or the perfusion mechanisms in our single ventricle patients. More importantly, when most of us athletes, when we desaturate in the level of legs, we have a really impressive hyperemic response that occurs that then just supplies increased blood flow to the legs. In our Fontan patients, we weren't seeing that. And what we were seeing is that they were hyperemic in the level of the brain for cerebral protection as opposed to supporting muscle growth. And that might lead to some of the things that we're seeing in some of those muscle deficits later on. So I know that was probably the longest one that I'm going to talk about, but that was something that we did just as an ancillary piece of equipment. Some testing ideas, alternatives. We always test aerobically, but we can also do isometric dynamometry. We did 20 Fontans versus 20 controls, and these were all kids that were essentially somewhere between 8 and 12 years of age, somewhere in that age range. And we did strength measurements in both the bilateral rec fem muscle. So we did a knee extension, we did a chest press, and we also did a bilateral curls, arm flexions. And the chest press was not what you're thinking of. It was not a 1RM max. It was a chest press on a isometric dynamometer where they pushed together. We found that there were significantly lower peak forces in our patients. We also saw some changes between right and left sides. So we're going to talk about that balance in a little bit as well, because at dinner last night, Dr. Hansen actually mentioned something about some differences in size that I thought was interesting, and we'll follow up with that. So resource ideas. What if we don't have treadmill? What if we don't have isometric dynamometry? There's some really good evidence that a 6-minute walk distance and speed correlates really well with VO2 in these Fontan patients. And so what we were able to do is we did a 6-minute walk. We looked at speed. We looked at peak heart rate. We also did a 30-second sit to stand. We did a balance test based on this. We also did a physical activity questionnaire. And we recognized that the 30-second sit to stand was able to be a positive predictor of exercise time and VO2%, as was 6-minute walk speed. The PROMIS physical activity questionnaire also showed us some evidence of prediction of exercise time and VO2. And believe it or not, the balance test actually was a negative predictor of exercise time. So if they were failing simple balance mechanisms, they were performing poorer on a treadmill. So if you don't have access to all this other stuff, if you have a chair and can do a 30-second sit to stand, if you can do a simple 6-minute walk in a hall, you can in some ways adequately and appropriately predict VO2 or exercise time in these patients. We steal ideas. I think sometimes we all want to be echo. I never did, but this is something called muscle sound, and this was actually in the performance model, and we tried this in some of our Fontan patients. We were doing bilateral rectus femoris scans, and what this does is it goes in and it looks at not only muscle size based on the circumference of the rectum, but it also will do these measurements of intramuscular adipose tissue. It will give you an idea of fuel rating and glycogen concentration. And the way that it does that is through pixelation of the color and water content that is binded to potentially glycogen within these things. So there's algorithms that are used. So we looked at this. We saw that our Fontans did have slightly different fuel contents and size ratings compared to our normals. And we also recognized that there was, on this particular, in our right to left differences, we had some significant differences in size between right and left within our Fontan group. And I'm not sure if that's because of some balance deficits or if many of our Fontan patients, at least the ones in children, most of their clinical interventions through catheterizations are through the right femur or the right groin. And I'm not sure if that's affecting in some way some of that right side thing. But we're also seeing some deficits in some of the cerebral or the peripheral blood flow that we're looking at right now. So barrier ideas, we know that whenever we deal with patients with congenital heart disease, it's really a complex multifactorial, multi-system physical deconditioning. So not only are there just the classic cardiac limitations, but you have everything from parental issues, you have musculoskeletal deficits, you have school and teacher and coaches concerns, which may not allow them to do things that they otherwise, there's this protection mechanism, if you will. We have parent barriers. We have failure to understand the importance of activity. We also have mixed messages from the care teams. Within our own center at Children's, we have very different approaches to how people counsel exercise and even utilize the stress lab. So this was some data that we collected on something called pain interference and catastrophizing. And we saw that there was an increase, if you will. Most of our patients had an increase in pain catastrophizing, which meant that they fell somewhere in the moderate to high level of pain catastrophizing. So when they were experiencing pain, it would definitely limit their activity. Not surprising, right? And we saw that it significantly correlated with age, as did pain interference, that as our kids go from ages 5, 6, 7, and 8 up into their teenage years, they're much more affected by this pain interference and catastrophizing that then also may help or explain some of their limitations. So chapter 5, finding some resources. That can be really difficult to do because in a center where you're trying to think about a cardiac rehab program, resources are not always available. You may not get the support, and from a billing standpoint, you may not always have the ability to justify some of those programs. And so I have a unique opportunity at being a professor at Marquette as well as working at Children's that I can utilize the facilities that we have at Marquette to do some of those things. So this is what we call our Athletic and Human Performance Assessment Center at Marquette. And what we do is this is where all of our D1 athletes train. And we've struck a deal with Marquette and Children's where we have a joint relationship where our kids with heart disease can come over and work out with some of our D1 athletes. And so it's been a really cool relationship because our D1 athletes get to hang out with these really kind of cool kids. They get to, idolize them in some fun way. But the kids get to run around and use and be a part of this type of an environment. We also have a research center there that allows us to do a lot of the testing. But this has been a really nice resource for us. And from a cost standpoint, Marquette isn't charging us anything for this. And so this is a facility that's already being used. It's already used by so from that type of standpoint, it's really good. So we have a joint IRB between the two, which has allowed us to do this. We are collecting data, and our kids can come over there, and they come typically anywhere from weekly to sometimes it's 3 times, 4 times a year. So they can get an initial testing and go through that program. With that being said, we originally started with something called the Stepping It Up program at Children's. And that Stepping It Up program was a multidisciplinary team that a lot of people have attempted to start. And so we had everything from psychology to physical therapy to occupational therapy to nutrition to myself as an exercise physiologist and the physician there. And that worked well, but it was somewhat patient intensive in the sense of some of our initial visits, and this was part of our own problem, were 2.5 to 3 hours in length after meeting with all these people. And then we would do what we called an initial assessment. We'd do a 3-month, a 6-month, and then a 1-year follow-up, and then we would graduate people through the program. It became quite intensive, and that led to this idea of measuring and improving kids' exercise success, which became Mike's Heart program, which is now the extension of Marquette. I wish I could tell you that it was an ego-driven decision to do Mike's Heart. It really wasn't. I work with some really nice people at Children's, and they actually helped me come up with the acronym, but it works, I think, nicely. So the relationship between Marquette and Children's has worked out really well. So we do a lot of different testing there. And so we have initiated programs. We have a Marquette mentoring system where we initiate students who will then be paired with one of our kids with CHD. And their kids now, this is a picture that we started the mentoring program probably 10, 15 years ago. So some of the kids that you see here, and they've all agreed for us to use this picture repeatedly, but there are 3 or 4 of them that are now all college students, and a couple of them are actually students at Marquette. And part of the reason for that was because of this relationship that they had met through their mentor. And college seemed like a possibility now because of that. And these other things, and playing sports were also part of it. So these are many of my Marquette college students and their mentee or mentors. And you might recognize Dr. Ronnie Jacobson on the end there, who was also part of this program, and she's now at Children's in Colorado. So this was just some sample data. We used to also give out Garmin's, and we would track data. And so we had one particular young lady who wanted to run a 10K, and she was working quite diligently towards that. And we thought about tracking her steps. And so we saw that right here when her high school year would end, her activity level would typically drop quite a bit because gym class would end and those support systems would die down. So this was a time for us to intervene based on those low step counts. And then again, sometimes right at the beginning of school year or change of weather in Wisconsin, things like that would also alter. So we would have to come up with strategies or plans to try and disrupt that. So I'll end very quickly with this idea of paying it forward. I've always liked the quote, and I wish it was mine, but it's not, and it's been used a million times, but a candle loses nothing by lighting another candle. And I've always liked the idea of mentoring not only the patients that we take care of, but the fellow exercise physiologist or anybody who wants to learn about it in general. And so in my idea of paying it forward, it's how do we change what we're doing? How do we think about things differently? How do we continue to stretch the box? Research and data is important to me. It really is. What's more important to me is seeing a kid want to go to college, or a kid want to do this, or a kid deciding that they can do something that they otherwise didn't think they used to do. So in 1995, when I started, I remember having to beg people to send kids to come walk on the treadmill because they were so afraid that something bad would happen and liability issues and things like that. And now it's a really nice problem to complain about being too busy. So with that being said, this guy, when he was first starting out, decided that he wanted to do something in exercise. Actually, I wanted to be a radio DJ in Southern California. But through the time, and I stole the picture of Casey and myself presenting some fun data at World Congress not too long ago, and my students at Marquette. And this is an event where my daughters, we work with a lot of our heart kids, and we have an annual zoo picnic, and we put on tattoos, and we do exercise and stuff like that. And this is actually a graduation ceremony that we have at the end of our program, where we do medals for medal, where people donate previous medals that they've either won through marathons or whatever, but they're like, this is just cluttering up my house. So they donate those, and then we give those medals with a certificate to the kids for their accomplishments for making it through the program. And that also then gives feedback to the people who donate those medals that they're going to somebody else. So with that being said, I'm now approaching a little over 22,000 CPETs. I've had 74 interns from 16 different colleges. I've worked with, in some capacity, about 47 fellows, and I've graduated about 1,300 exercise phys, AT, and PT students. And so I'm going to grab my coffee now, and I'm going to turn this over to the much better and much more important talk, which is going to be Casey Vogel talking about physical therapy.